Hello again. Today I'm going to cover the chapter on complications of procedures. So I'm going to go through briefly some of these complications. There's certainly more information in the chapter. For upper endoscopy, that is esophageal-gastroduodenoscopy, where you look in through the throat, down into the stomach, and a little bit beyond, complication rate is about 1 in 2,500. Complications being bleeding or perforation where a hole or tear develops. Those are the usual ones. If a feeding tube is to be placed at the time of upper endoscopy, complication rate is about 10%. Most of the complications are infection, which are tried to be avoided by giving the patient antibiotics before the procedure. And bleeding and injury to other organs can occur with that feeding tube procedure. You have to remember these procedures are usually done in high-risk patients who have multiple risk factors and comorbid conditions. There's an endoscopic procedure called endoscopic mucosal resection. This is where deeper biopsies or removal of polyps and growths are undertaken. Complication rate generally quoted at 5%. If endoscopic stenting of procedures is done, overall complication about 12%. Stent migration, perforation, bleeding are the usual things that can go wrong. There is a small intestinal endoscope or enteroscope that is used to look at the small intestine. The complication rate here is about 4% because it's a much longer bit of intestine that you're trying to traverse. There may be adhesions or angulations and so forth. Endoscopic ultrasound, where a ultrasound is on the devices on the end of the endoscope. The complication rate about 5%. Some of it, of course, depending on what you're doing with the procedure. Complication rate for transesophageal echocardiography, or TEE, is about 1 in 5,000. This is where, again, there's a ultrasound device on the tip of the scope, but the scope is blind, so you're not really able to intubate with visual cues. This is kind of similar to placing dilators in a patient, bougie type of dilators. And on occasion, the cardiologist has to contact one of us to try to help place the scope, or we have to do dilations or other techniques to try and get the TEE scope, transesophageal echoscope, down. There's an amazing device called capsule endoscopy, where you swallow a capsule that takes pictures throughout the intestine. And the main issue there usually is capsule retention. This may occur at the site of a growth or cancer or stricture site. That retention rate is about 1%. If you think you have such a patient, there is a pill that dissolves that can give you an idea if your capsule is going to hang up there. Colonoscopy, which is one of the more common procedures that gastroenterologists done, the overall complication rate, you have about a 3 per 1,000 rate of perforation where a hole or tear develops. Bleeding rate about 6 per 1,000 procedures, but up to 1% of polyps are removed. Here, if the patient had adhesions or a lot of angulation at the sigmoid colon, this may increase the risk. There are lectures and advice given to doctors about difficult procedures and how to accomplish them safely. One of the latest discussions, and by latest I mean a number of years ago now, was a water immersion technique. And this water immersion technique was very helpful if you have a difficult sigmoid colon to negotiate. And I can remember clearly I had a colleague, another gastroenterologist, who I did a screening colonoscopy on, and right before I did his procedure, his wife told me, well, there's a lot of trouble with that sigmoid colon, and he's had difficulty with that. And so because of that, I went ahead and did a water immersion technique, and everything went great, and it was very smooth and fairly straightforward procedure. And afterward, the wife told me one of the prominent gastroenterologists here in town tried to accomplish his procedure, couldn't get through the sigmoid, and told him he had cancer. Well, he didn't have cancer just because he couldn't negotiate the sigmoid colon. Anyway, obviously that upset the patient and his wife quite a bit, and it goes back to our obligation as physicians. You never tell a patient they have cancer unless you know for sure they have cancer. It reminds me of a case I had where I took a polyp out, looked totally benign. Pathology came back cancerous, but I couldn't believe it, so I just waited and I talked to the pathologist. I was going to talk to the pathologist, and they called me, or they checked on it and found out, oh, that was a different patient. That was a mistake. And I was very happy that I never called that patient and told them that they had cancer. And it brings to mind another case where I was in the office and going through patients, and a patient was called in, and I looked at the chart, and I think the name was the same, but it looked like the patient had this advanced cancer he wasn't really aware of. And I was about to say something when I checked, beforehand. Fortunately, I checked his date of birth and his name and everything, and it turned out, no, it's a different patient. And he had come in when he wasn't supposed to because he was tired of waiting in the waiting room. He could have gotten quite an ugly surprise. Fortunately, it didn't happen. Going on to ERCP is endoscopic retrograde cholangiopancreatography, where you take a scope that's designed to look at the bile duct or the pancreatic duct and also do therapeutics with it, such as removing bile duct stones or treating infections or making diagnosis of bile duct cancer or cancer of the pancreas. At any rate, the overall complication rate there is generally listed as about 2% risk of bleeding, 1% risk of perforation, 1% risk of infection. And most of this has to do with when you cut open the bile duct, you need to oftentimes open it up so you can get a balloon in there and clear out stones. So that increases the risk of perforation and infection. The overall complication, 10%, which has to do with pancreatitis or inflammation of the pancreas, because when you're manipulating the catheters in this area, you may inadvertently get involved with the pancreatic duct, and as such, you may trigger some pancreatitis. And there's a lot of techniques and issues related to trying to avoid that particular problem. And that usually has to do with using a wire or placing a pancreatic duct stent and other techniques to try and avoid difficulty. Infections can occur, and there's been recent information and warnings. I say recent, this is a number of years ago, and it goes back even further, having to do with resistant bacteria in the elevator channel area and a biofilm that's there despite disinfection of the ERCP scope prior to the procedure. So there was some more guidelines in terms of cleaning the ERCP scope. This is also called the duodenoscope, to try and avoid that infectious complication, because you do not want to introduce infection, particularly resistant bacteria like Pseudomonas, into a bile duct that's obstructed, and you have a closed space infection that then can become deadly. The duodenoscope, which is used for ERCP, is like, I tell patients, it's like driving down the road, but you're not looking out the front window, you're looking out the side window. So it's a side viewer. And so you have to develop ability to negotiate through the stomach and into the small intestine and a little bit further, and park yourself up next to the bile duct. So those issues are covered in the chapter here on complications. The failure rate for ERCP is about 5%. Sometimes it's just not possible to do this at the time that you're trying to do it. And I was fortunate in San Antonio, I had a colleague who I could send those very difficult cases to, who had access to endoscopic ultrasound, which can facilitate ERCP procedures and some other techniques that could be done. And he would be able to usually accomplish that without any further type of procedures or surgical invasive procedures. So there's also a procedure where special radiology can go through the liver when the bile duct is dilated and can access the bile duct that way. So there are other ways of getting around that failure rate of 5%. And that mostly has to do with bile duct may be obstructed or the anatomy is difficult. There's a diverticulum or outpouching in the area that the bile duct or pancreatic duct comes into the intestine. And so there can be difficulties. And there's special cases like people that have had gastric bypass. You can't really access the bile duct very easily at all. It's been closed off to access through the stomach and has to be accessed a different way. There is a risk with anesthesia. This is a very small risk, generally quoted as 1 in 100,000. Of course, it does depend on the medical condition of the patient and the type of surgery that the patient is undergoing. And all of that is pretty well outlined in articles and texts. I don't go into a lot of detail as far as that goes. I do conclude the chapter by saying it's important that the doctor should judge and understand that the risks of the procedure itself are less than just leaving the situation or disease process the way it is. It also is important to realize that usually everything goes okay with procedures. It's important to know the doctor who's doing the procedures. Have they been doing, what's their complication rate? Have they done plenty of them? There's been discussions about ERCP that they should only be done in high volume major medical centers. Not very practical though, I think, in a lot of cases. A lot of times an endoscope or scoping can give a diagnosis, a specific diagnosis for which then treatment is rendered, and it can be a very valuable tool, both diagnostically and therapeutically. And with that, I think I'm going to conclude this chapter talk.